tried to find solution to the case and so on. So it was a very nice experience for me, and some of the ideas were born in this study group. And now we can speak about tooth agenesis. We can see that the prevalence of tooth agenesis varies among populations. You can see the values in this column here. And in some population is most frequent the lower premolar agenesis, and in other ones, upper incisor agenesis. And what we can state that the trend now in upper lateral agenesis is to close the space, because we know that in literature it is often described that long-term follow-ups when we open the space are very poor about aesthetics, about appearance, about periodontal conditions. So the trend now is to close the space in these cases, because we have a long-term success more predictable. But what happens? It happens that orthodontists, the literature says something, but orthodontists very often try to open the space. So there is a gap between literatures and orthodontic habits. So you can see here the problem when you open the space, because sometimes you can have the bone is very thin in that area, so you can have a necrosis over the ears, the papilla can disappear, and so on. You know these things. There is no need that I remind you. But only that my dream is that the future will be that we always tend to close spaces, not to insert implants in anterior regions, because implants in anterior regions, it's a big problem over the years. We know this. And besides, there are some indication to space opening, because, for example, in a unilateral cases where you have a big dimension of the canine in comparison with the lateral one, the lateral incisors, maybe it's difficult to mimetize, to have a symmetry of the arch, a symmetry of the smile, closing the space in this way. Also in skeletal class 3, where you have a concave profile, it could be difficult to close the spaces. But nowadays, we have Miniscrews. So I will show you a case where I close the spaces, because if we succeed in moving all the teeth forward, maybe profile can maintain his appearance, and there is no problem. Obviously, we have to consider also the cost benefit. So the underlying malocclusion is important in deciding our treatment plan. That's my example. You can see here a little girl. We have a concave profile, so it would be a contraindication to open the space, but by Miniscrews we can treat her successfully. You can see here. It's an asymmetrical case. You can see that in the lower arch, you have an asymmetry of the position of the canines. And if you use a class 3 elastics here, what happens is that the asymmetry will worsen. So you have to use an intra-arch mechanics by Miniscrews, by using a Miniscrews. You can see here, very simple, you can put 2 Miniscrews, 2 centralized springs that work at the level of the center of resistance of the upper teeth. And now you see a transparent bar. This transparent bar is a little different from classical ones because it is divided. Why it is divided? It is divided because when we come from molars to premolar, the arch is more constricted, is narrow, and if we want to avoid fenestration in this of the mesal root of the molar, we have to use this kind of bar or a classical bar, activating with a contraction of the TPA to prevent this this fenestration, this possible fenestration of the bone. Here is the treatment progress. You can see that there are no problems, and here is the final. And in this case, the canine was little, and the patient refused to do some prosthetic rehabilitation, but maybe at adult age, she can always do. And profile, you can see the profile is the final one, and here is the initial. The profile is maintained, no better, no worse, is maintained. The appearance is pleasant, so I'm happy of this treatment. Now, if we want to open the space, we have the problem to maintain the space until adult age, until insertion of implants and so on. We have some option. We can use removable plates, but removable plates are very, very uncomfortable because they require a lot of compliance from the patients, and you have a continuous pressures on the palatal mucosas. You can create a desepithelialization of this mucosa over the ears and so on. So removable plates maybe are better not to use in these cases. Better are adhesive bridges. All we know that adhesive bridges, but adhesive bridges in these patients that have a very short clinical crown because soft tissues are not still matured, maybe it can be a limited rotation of these adhesive bridges, and sometimes they require to increase rotation, some invasive procedures on LT3, some preparation, and so on. So also adhesive bridges have problems because the retention is very limited. And besides, we have also a problem about bone, the bone maintenance of this patient, because we know from the literature, this is a study from Nanda, it's a very great study. You can see that just when you have finished treatment in this patient, you lost a lot of bone. This study is on plaster models, and this is on CBCT. It's the sample is the same, the patient, but you can see that the bone width has decreased from 17–25% just at the end of the orthodontic treatment. It's a huge loss of bone. And also the labial concavity doubled in some cases, and so on. But obviously the height is good because these patients are growing, so the height is good. We have so many problems with the height of this of the growth process of these patients. And of course, if we with this loss of bone at adult age, 60–80% of these cases need a bone graft when we insert an implant. The majority of these cases needs a bone graft. Now the question is, can we prevent this bone resorption? Yes, we can. We know that if we load the bone, if we put a stimulum, a mechanical stimulum to the bone maintaining its density. And you can see if we apply microstrain to the bone remains the same, and the resorption is prevented. And you can see from this micro-CT, for example, here, from the micro-CT, the density of the bone around an implant or a miniscrew is the same that a natural teeth. It's the same as in the natural teeth. And that's great, because we know that we can maintain the density of the bone around a miniscrew. And in literature, there are a lot of examples of these studies. For example, this one, you can see that they inserted a miniscrew from one side, and the other side was the control one. And they measured the density around the miniscrew. You can see that just after 3 months, the bone density around the miniscrew increased. So it's very important to understand that the Miniscrews have this possibility to maintain bone around them. The first author that had the great idea to use Miniscrews as bone maintainers was John Graham. And this is the first article in 2007. You can see the first article, and here is the technique. You inserted the Miniscrew vertically, and then he built a crown, a temporary crown, he adjusted the crown in the mouth, and so on. And you can see the intraoral X-ray. Now, here there is a splint, and the splint, to splint a Miniscrew with adjacent teeth, it's not a good idea because patients are growing patients. So we have vertical growth. In some patients more, in some patients less, but almost we have vertical growth. So to splint is not a good idea because I can create an infra-occlusion of the adjacent teeth. But the idea was very good. And for example, here's another article from Paquette, more or less the same technique. You can see these pages, these images, more or less are the same technique. And what Graham stated is that around Miniscrew, we don't have a complete osseointegration. This is true, but if we define osseointegration as bone to implant contact, we know that it isn't a total osseointegration, but it's a very great integration, because we know that, for example, in animal studies, the bone to implant contact is about from 60 to 80%. So it's not a complete osseointegration, but nearly a complete osseointegration. And this means that the Miniscrew is ankylosed. You don't have a movement or a growth in the area around the Miniscrew, because there is a partial osseointegration of the Miniscrew. And if we listen to Kokic told us not to use Miniscrew in this way, vertical in the alveolar process, because a vertical angular defect can be created. Because the Miniscrew is like an ankylosed tooth, and you have an infra-occlusion of the Miniscrew. And for example, another example from the clinic in Aarhus, you can see we use this Miniscrew for retention purposes, and you can see that just after 1 year, this molar has lost his contact with the upper one, because an infra-occlusion is created by the Miniscrew. This is another very nice article. In this article is described a boy that lost his upper right lateral incisors, and they thought to insert a Miniscrew to preserve bone in this situation. And when you notice the intraoral X-ray follow-up X-ray, you can see that over the years there is an infra-occlusion in this area, because if the space is little, or if the Miniscrew is not centered very, very precisely, you can destroy one papilla, one bone peak on one side. Because here we have growth, but here we hadn't growth because the space was very narrow. Here's another article. This is Cope. In this article are described 2 case reports. You can see here that in the first patient, we have a lot of space. In this case, we can use a vertical insertion of the Miniscrew, obviously, because we have a lot of space. But we all know that when we open the space for the upper lateral incisor, are very rare the case where we have a lot of space. Generally, the space is very limited. It's very difficult to open properly for an implant insertion in this patient. In fact, you can see in the second patient here that the space is narrow, and he was forced to use a mini screw with a narrow diameter. The diameter is little in these cases, because he knew that if he used a big one, then there were problems. But we know that when we use with this thin mini screw, maybe a fracture can be real. Another article, this is by Wims, they stated they observed this infraocclusion in some cases, and they say that it's not so common. But we have to think that we have to choose if we want a technique that we can see sometimes a problems, or a technique where we can see never a problem. I prefer not to see never a problem in my patients, because it's better. Even if it's one or it's two, it's important not to have problems. And so they suggest to use the mini screw small enough to avoid interference with the alveolar growth, because of this problem of infraocclusion of the mini screw with the vertical growth of the alveolar process. And you can see here at adult age that the real problem is not maybe the height, because the height can develop, but it is the width of the alveolar process. The width of the alveolar process is the real problem. And if we insert a narrow mini screw, maybe we cannot prevent this problem properly. Here's another example. You can see this concavity. This is the problem for the surgeon to insert, to obtain a nice aesthetics in this clinical situation. And if we go to the literature, this is confirmed that the width is a problem. You can see in socket preservation technique, this is an example. This is a review of the Eastman in London, Eastman Institute. You can see that when we analyze the height, you can positive value. We have some differences, but you have a result. But when we speak about the width, you can see that you have almost negative values over the years. Only to say that to maintain the width is very difficult. It's very difficult. And also, as I said before, when you use a very thin mini screw, we know from literature that when the diameter is less than 1.6 millimeter, the fracture risk is very high. So we cannot use very thin mini screw, because we will have a problem. And another problem is also mini screw failure, because we know that there is failure in this zone, because the bone is very thin and so on. And when you have a failure in this very static zone, you have a problem, because what happens is that bone is resorbing, even if the mini screw is clinically stable, okay? So you have this problem, you have this necrosis, you realize that you had necrosis after you had, because clinically maybe the mini screw can maintain its position, especially if you use long mini screw. But this is a problem. You can get a necrosis, a failure, in the area where you cannot afford to have. And here, for example, another case report, you can see here that in this young patient, this is the vertical insertion of the mini screw. You can see over the years the infraocclusion we've said of the bone, you can see how the bone, we have two vertical defects around the miniscrew. Only to confirm what I've said before, that miniscrew is ankylosed, and it's sometimes dangerous to insert this miniscrew vertically. And so my idea was to insert, my idea together with Professor Melsen was to insert this miniscrew horizontally, because horizontally you don't have problems about growth of the vertical alveolar process. And for example, the idea was born in the clinic because they forget this miniscrew after the patient finished his treatment. They forget this, and they realize what happened. Oh, we have bone here, and now you can notice how much resorption you had on the controller side. It was a lucky situation. And then what they did, they observed this, and the first thing they began to study this, and they study in dogs. You can see this article is a with Professor Uya in USA. And what they did, they studied teeth in the dogs, and from one side they insert the miniscrew, and on the contralateral side they use this contralateral side as control side. And you can see after 6 months that here the width is maintained, the density is much more than this contralateral side. Here's another example. You can see here the density, the width is more than the other side. And that was very interesting. That's what it is. So the first experience was to insert this miniscrew it was a case series of patients, only 5 patients, and we tried to check these patients over the year. They received 6 miniscrew as a temporary pontic, and we checked clinically with the intraocular and the radiographic images, and we took these images at 2, 3 years, and 5 years follow-up. And yes, I will describe the technique in just a few words. You can see this is an Aarhus miniscrew, but it's not important Aarhus. You can use the important thing that you have a screw with a bracket head type, so you can insert a wire here. And this miniscrew is inserted at the coronal third of the length of the roots of the adjacent teeth. You can see in this peak. And then you build a stainless steel sectional wire, 21 by 25 stainless steel sectional wire. And very important that you make this band, this 90-degree band, because when the patient functions and he chews on the pontic, it's important to have a torque deformation of the head here, a resistance here. It's important to have this degree, because if you don't have this 90-degree, you design your sectional straight. What happens is that all the load is on the ligature, and the ligature can break. So it's important to have this configuration. Can you apply, obviously, a metal primer, a bond agent, and so on? And you can build directly in the mouth if you prefer, like in this example, or you can receive from the lab a pontic. You can adjust the pontic in the mouth. It depends on your personal preferences. There is no problem about this. As you can see in this patient, the colleague adjusts the pontic in the mouth using a pontic from the lab. Then you can refine, you can finish with finishing procedures, silicone points, you can use diamond bars and so on. The important thing that the point must be very smooth to have a good hygiene of the patients over the years. You can see then you can ligate the pontic in the patients and so on. Now, with this kind of mini screw, it's a little difficult to ligature because you have to make a loop here, then you go around the neck of the mini screw, and then you make another loop here, a 2 points ligature. It's not so easy. So you can use also this, for example, this mini screw. You have a bag head. It's easier. It's very easier to ligate the sectional. So it's not important. I suggest also to use this one because they are very easy to ligate. And after that, you can apply a flowable composite to obtain a smooth surfaces for comfort of the patients. Now, what's happened over the years? You can see that no inflammation around the pontic, obviously, but some inflammation around mini screw. But we know that we can have inflammation around mini screw. It depends on the degree of hygiene of the patients. And if it happens, you can increase your oral hygiene procedures. You can use daily chlorhexidine map rinses, no problem. But it's very interesting to see that no bone resorption around mini screw happened, because we know that in the palate we have a very high, nearly 100% success, because the cortical plate is very thick, the cortical plate of the palate. So the success when we insert the mini screw from the palate is very high. We had some ligatory breakage. I spoke about this because the first one I didn't use the 90 degrees bend, so all the load of the pontic was on the ligature, and some ligature broke. But now, if you do a 90-degree bend, you have no problem. And you have also to check the vertical growth of the patient, because in some patients, if the vertical growth is very high, you have to adjust the wire occlusally to let the growth happen without an interfering with the mucosa. A discoloration of the pontic can happen, but there is no problem. You can easily modify and adjust. And some clinical example, for example, this is Sarah. You can see a bilateral case of upper lateral agenesis. There is also transposition here of the canine with the premolar. And when at the bonding day, we can insert the pontic with the wire, and we can insert the mini screw. This is the intraoral X-rays. These are the intraoral X-rays. At 2 years follow-up, this is the control. At 3 years and at 4 years, you can see that in this case, we had the discoloration of the pontic, and we had also an impingement because the vertical growth was very high. But you can adjust it. There is no problem about this. You can adjust the wire without no problem. You can see that the cortical plate is good, and it remains very thick. Here's the final panoramic X-ray. Here is another example, only to show you the technique. It's a monolateral case, and you can see we have an L configuration here of the wire, insertion of the mini screw, and follow up at 2 years, and 3 years, and 5 years. 5 years follow up. You can see that no bone resorption around the mini screw. The mini screw stay well in the palate without no problem. And this is panorama, follow-up panorama X-ray. So, clinically, the insertion of the Miniscrews and the use of this pontic is good. It's only a case series, not so much cases, but it is promising. It is promising to use this pontic in the patient. And if you want to see the article, you can see in the Angle Society website, because the article is in the reading list for the examination, and it is free. You can download freely the manuscript, the article, and there is another article in the JCO here in 2011, if you want to check the technique. And this is an open source, mouth and teeth, and it's another case report, and you can download freely. There is a case report described about the technique. Now, I want to point out some mistakes that happen, because some colleagues want to try the technique. They asked me, so I want to point out the mistake, because if we do mistake, maybe something can be wrong, and we have to point out which are these mistakes, with common mistakes. The first one is that we have to insert the Miniscrews as occlusal as possible, because if we insert the Miniscrews very gingival, very near the bottom of the palate, the wire becomes longer. You have a deflection of the wire, and it will be a disaster. So we have to insert the Miniscrews as near as much possible to the top of the Gero process. And the 90 degrees bend, it's mandatory, and the ligature of the wire must be correct. We need the 2-point ligature, because only 1-point ligature isn't sufficient. And we have to monitor the pressure of the pontic on the mucosa. We have to check the vertical growth of the patients. Here is an example. For example, here you can see that this wire is straight. It's wrong. It's wrong. It's not a good application of the technique. And this is in this patient, the configuration is correct, but you can see that I have only 1-point ligature. I have no wire on this side, and that's wrong. That's wrong. Maybe because this kind of Miniscrews are a little difficult to tie. Ligation is difficult. That's why you can see this. And in some patients, we noticed that the insertion was bicortically, and you can see that after 5 years follow-up, the width was maintaining. But nowadays, I've changed. I do, for example, here, this insertion is wrong, because I want the tip of the Miniscrews here. I want here as to have the greatest effect of the technique. I will show you a case. Just a moment. That's important, that the tip must be here. You have a very, very great clinical effect. And that's why now I use a surgical guide to insert this Miniscrews, because I want to be very sure of the length of the Miniscrews, of the inclination of the Miniscrews, and so on. And I can decide on the computer with my lab in Bologna. It's very easy. When the patient, during the CBCT exam, you have this DIMA, because what happened to calculate the dimensional error. And you can see that we can design the Miniscrews, the length, the diameter, and so on. We can insert. We have also the soft tissues information of the patients. You can see here the soft tissue. So we have all the information to make a digital insertion and then to do in the patient in a more precise way. Here's an example. You can see the Miniscrews and so on. And we receive from the lab the surgical guide, very simple. You can see that this surgical guide has some cuts here. It's very important because when you put the surgical guide in the mouth, you have to be very, very sure that it is in a very good position. So I need this cut to realize if it is okay or not. And personally, I like also these spaces here because I want to check with my eyes during insertion if the plate of the Miniscrews with the mucosa is okay. It's to have the same inclination, the same, to be parallel to the mucosa. And in literature recently, there are articles about the use of these Miniscrews retained pontics. And this is a nice article from Eastman Institute from Rochester in New York, in the USA. And the question is, they asked about these Miniscrews retained pontics are useful. Are we sure that they are useful for the patients? And then they went into the literature, they read all these articles, and they identified 6 articles that mine article was included. And they concluded that a limited evidence shows that MSA supporting pontics are useful. So there is an evidence, there is an advantage for the patients. And that's very important to know, because when we do something in the patient, we have to be sure that there is some evidence based of what we are doing. But what they warn, what they tell us, that a three-dimensional imaging, it's necessary, because with a 2D images, we don't know really all the story. So a CBCT, it's very important to understand deeply what happens in the patients. And that's why now we are doing another study in collaboration with the Marseille University and Montpellier University. We are inserting Miniscrews in these adolescent patients in 26 genetic sites, and we make a CBCT at T0 at the initial time, and a CBCT after 2 years, to see what happens in a 3D way. And I will show you some clinical example of this work in progress. You can see a bilateral case like this one, insertion of the Miniscrews. We make the sections, stainless steel section wire. You can see here that there is a concavity here. There is a concavity just at the end of orthodontic treatment, like Landa stated in his study. And you can see that at 2 years, this is the appearance, and this is at 4.5 years. And that's a very nice appearance of soft tissues. You can see, to compare here, T0, and over the years, soft tissues overgrowth. It means that the bone is maintained and the physiology of the bone is good and there is no problem in the patients. And if we go, this is clinically, but if we want to go through the CBCT, you can see that the width is well maintained, the depth of the cortical plate is good, also the growth, obviously there is also a growth of the patient, but the growth happened in a physiological way in these patients. You can see here, as on the other side, here, and this is follow-up. Another patient, this one, for example, initial and final, you can see that the growth is okay. on the other side. Here is another patient. Also, even if in these patients that the alveolar process is very thin, you can see here, it's very thin, but it is maintained. It is maintained over the years. And that's important. That's great for the patient. Obviously, when we measure these patients, we have to use a standardized way, the same way. So we have to orientate to put the CBCT in the same manner in all the patients. And we use Nanda method, this one, to orientate the CBCT in the same way. And then we can make tables to have some numerical values. You can see here that the bone width, the values, the yellow one is at T2, at the final one, and this is T0, the initial one. You can see that the values are good. This patient was treated by Dr. Tom Ongena, that is from Mercy University. And this is the labial concavity, the bone 8. The values are very good. This is the other side. And also here you can see that the values are similar. Then we have to put all this value in a statistical analysis at the end. The study isn't finished. To understand if these differences are statistically significant or not. But for now, what we see, for the patient treated until now, you can see that the bone width, the labial concavity, the value is very, very, very similar. So it means that the Miniscrews have succeeded in maintaining the bone in these patients. And when we use an horizontal insertion, it's very useful also in posterior agenesis. For example, upper lower premolar agenesis. Because in these patients, a vertical insertion is not useful. And for example, in these cases, you can see this young girl, she has a skeletal class 2, a very huge skeletal class 2. You can see here the retruded chin and so on. But this is the overjet, obviously, a class 2, a very huge class 2. This is the lateral X-ray. And in these cases, what we want to do when we have multiple agenetic cases, what we want to do to reduce the number of implants at adult age. So a good idea in this patient is to mesialize the posterior teeth to reduce the number of implants. And for example, in this patient, we mesialized the canine ear, we mesialized the molar ear, and at adult age, what happened that he has to put implants only in first molar region. That it's much less than all these teeth to insert all the implants for all these teeth. And here, so we decided to extract this tooth, to mesialize the molars, and to extract the baby canines, to mesialize the permanent canines. Here is after extraction, here after mesialization. And what happens here that you can see that we insert the 2 Miniscrews to maintain. And if we perform a CBCT of this case, you can see that this is the initial one and this is the final one, that the vertical growth is good and the width is good. And here's the contralateral side. You can see here that the vertical growth will happen and the width is clinically good. And another example, for example, in this patient, multiple agenesis, obviously, here we have to maintain these 2 teeth until adult age, and we want to use premolar to mimetize canines and to mesialize the posterior teeth. Another example is also the use of the Miniscrews in the low incisor agenesis. You can see here, this case is published in JCO, if you want to see, in 2011. And this case is, you can see that the marginal, the alveolar crest is very thin. It's very thin from the beginning. And what we do, I use, in this case, I use an orthopedic miniscrew, a very short miniscrew, not an orthodontic miniscrew, and I perform the flap, and I use the Maryland bridge. You can use miniscrew in connection with Maryland bridge. There is no problem, because here I feared that the load was too much for the cortical plate, because the cortical plate was very thin. So I prefer to perform a Maryland bridge that in lower tier Maryland bridge is good, because you haven't occlusal contact, and the stability is higher than in the upper arch. And so this was the solution. And you can see that after 4 years, the soft tissue appearance is very good. You can see the gum of these patients, and also the intraoral X-ray, you can see that there is increased density around the miniscrew over the years, and also the CBCT is good. You can see after 2.5 years. And if I use a 3D reconstruction, here obviously there is a cortical plate, a buccal cortical plate, but very thin. We know that CBCT sometimes don't read very thin cortical plate, but at the follow-up you can see that the bone is very good, very thick, and so on. Now, I think that this is the last case. This is Dana, 16 years old, and this is a iatrogenic case. This is a iatrogenic case because this girl came to my office very sad, because what happened here that he received an orthodontic treatment, but you can see that the aesthetic is not good. We have an agenesis of the upper lateral incisor, but the major thing is that you can see here, we have a generalized resorption, because the orthodontic treatment was very long, and we know from literature that the root resorption is correlated with the treatment duration, treatment time. So you can see that in the lower arch we have still a cavus P, no treatment, but we have the root. That's important. But in the upper arch we have a lot of resorption, and we lost 2 teeth. They lost 2 teeth. Very sad. And here is the lateral X-ray. And if we go to the CBCT, you can see how much was the bone loss. How much was the bone loss? Very sad. I'm very sad for this patient. But now what happens that the patient went to surgery for a reconstruction of the alveolar process, and you can see here that the surgeon reconstructed the alveolar process, and the result is quite good. We have obviously always to treat this patient. Maybe in the lower arch we have to intrude the incisors to level the cavus P, but in the upper arch the treatment will be very minimal, because this root are very short. And here is the occlusal view. You can see now we have to maintain, because she is 16 years old, but we know from literature that we cannot insert at 16. There are a lot of studies from Birte Tilander about that. You have a very great infroclusion. We have to wait. And I will use miniscrew to maintain this bone, but also I will change the technique, because in this situation, what happens that I have an occlusal load very high. So now what I will do here, I will use an orthodontic miniscrew, but I will use this miniscule, because you can see you have this ring here. You can insert this ring on the head of miniscule, and you can solder a temporary foot on this ring. But it's important because you can see this is the wire solder, or you can you have also different height of the ring, and that's important because your lab can build an appropriate ponting for this patient after the horizontal insertion of the miniscule. And by using this, the patient can choose. That's important. It's a very different situation, like for example in premolar areas, different situation from an agenesis of upper lateral incisors. But I think that this miniscule have also 2.3 diameter. So the resistance to occlusal load is very high. And that's what I will do in this patient. So some conclusion. That vertical insertion, in my opinion, is to avoid because the adequate space is rare. We can make mistakes, especially young orthodontists. During insertion, you can not be very centered in the alveolar process. We can have fracture, we can have miniscule failure, and we cannot use in premolar agenesis, and what I think that in some cases the dimensions are so little that they cannot able to maintain the proper width of the alveolar process. So I don't suggest to use a vertical insertion. I thank you very much for your attention.